Hallux valgus. The anatomy of the first MTP joint is stabilized by the collaterals, the intrinsic muscles, and the extrinsic muscles. It is notable that no muscle inserts into the first metatarsal head, and that the deep transverse ligament connects the sesamoid to the second metatarsal itself. On the plantar surface of the metatarsal head, there is a crista, or bony ridge, that keeps the metatarsals in situ. The hallux valgus is when there's a misalignment of the first MTP joint. There's lateral angulation of the hallux itself. And metatarsus primus varus may be actual medial deviation of the first metatarsal head. And a bunion deformity, therefore, is caused by the medial metatarsal head being uncovered and a bony prominence or medial exostosis causing most of the patient's discomfort and pain. Pathophysiology of this is important. It is often asked in boards questions. The medial first MTP joint capsule stretches, the lateral capsule contracts. Both the FHL and the EHL sublux in the lateral position to the first MTP joint axis, and the muscles that were once stabilizing are now the primary deforming forces. The bony anatomy, the crista and the metatarsal head, eventually erodes, allowing the sesamoid to sublux laterally. As the first metatarsal head moves medially, the sesamoids maintain their position relative to the first and second metatarsal, relative to the second metatarsal head, and are therefore imaged as being more lateral on an AP view. Now, the pathophysiology, this is important in hallux pronation, is caused by the abductor sliding under the metatarsal head and losing your abduction force. Since the adductor and the sesamoid sling insert in the proximal phalanx, the hallux now spins into a pronated position. The etiology of this is often debated. The hallux valgus was a rare deformity seen in Japan before the introduction of westernized shoe wear. But nonetheless, even in the 1970s, when this was ubiquitous amongst Japanese footwear, there was still a high incidence of bunion deformity. So therefore, the question of intrinsic factors was raised, and indeed it is known that 60 to 70% of patients who have a hallux valgus will have a family history of same. And of course, this is common in juvenile hallux valgus to have a heritable incidence. Other risk factors have been associated with a tight gastroc, severe planus or flat foot, and joint laxity, including generalized joint laxity from Ehlers-Danlos loss or any other collagen disorder, an injury or an amputation of the second toe, allowing the first toe to drift into that space, or systemic diseases including rheumatoid arthritis and gout. Anatomic considerations are also given to this. The oblique distal metatarsal articular angle, or DMMA, is common in juvenile bunions and must always be identified for fear of failure of any surgical procedure if this is missed in the diagnosis. Physical examination requires assessing the deformity of the MTP joint itself, or valgus and pronation, identifying the medial eminence, dorsal osteophytes, and the IP joint to determine whether there's a hallux valgus interphalangeus. Examining the entire foot, pes planus is often associated with Achilles contracture. Was also seen medial column hypermobility, particularly the first tarsal metatarsal joint, and lesser toe deformities with crossover, second toes, hammer toes, and plantar metatarsal callosities over the central metatarsals. Radiological evaluation is often asked in boards. The weight-bearing X-rays and AP lateral and oblique measurements of the hallux valgus angle is normally less than 15 degrees. Intermetatarsal angle is less than 9, and the DMMA is normally less than 10 degrees. Sesamoid subluxation can also be evaluated from the AP view, and the first metatarsal length relative to the second is often considered. Sesamoid subluxation is important, as this needs to be addressed. as this is a risk factor in failure of the procedure. Postoperatively, incomplete reduction of the sesamoid is a high risk for recurrence of hallux valgus and also just of pain. Signs of hypermobility in the first tarsal metatarsal joint are gapping or oblique subluxation of the first MTP joint on X-ray, second MTC arthritis, but cortical hypertrophy is not a valid indicator of first tarsal metatarsal incongruence or hypermobility. Oftentimes, the angle of the joint itself will allow further subluxation, and this should be assessed carefully on an AP radiograph prior to considering any surgical procedure. Congruency has also been established as one of the criteria in restoring to normal for risk of higher failure rates if this is not addressed. And traditionally, congruency has been classified according to Don Baxter as mild, moderate, or severe based on the degree or percentage of uncoverage of the metatarsal head. Now, treatment of all hallux valgus surgery initially, or hallux valgus condition should initially be treated in conservative fashion: observation, shoe wear modification, wide shoe box, stretching the shoe over the bunion itself, bunion pads, orthotics, and anti-inflammatory medications. It used to be said that any patient with a bunion should be left until such time as their condition was significant enough to warrant surgery. This, however, is no longer the case, as in the old days, bunion surgery was somewhat unreliable. Now I think we have very reliable surgery, and so therefore to prevent the first MP joint developing significant arthritic change, earlier decision-making in terms of surgical procedures is warranted. Now, there are over 130 surgical procedures, and we don't intend to go through all of those. The most common surgical procedures these days would be the Chevron osteotomy, the scarf osteotomy, and the Lapidus first tarsal metatarsal fusion. The decision as to which type of surgery is based on the various radiological angles. In a mild hallux valgus, HV angle of less than 20 and an IM angle of less than 13, a distal osteotomy, such as a Chevron osteotomy, and a distal soft tissue release, such as a modified McBride, would be the appropriate treatment. Moderate is HV angle of 20 to 40, an IM angle of 13 to 16, and this could also be a proximal osteotomy or a scarf osteotomy and a distal soft tissue release. And severe, HV angle of greater than 40 with an IM angle of greater than 16, again, can be considered either as a proximal or concentric osteotomy, a scarf osteotomy, or a first tarsal metatarsal fusion or Lapidus, along with a distal soft tissue release. An exostectomy, or a silver procedure, is used to supplement other procedures. It is rarely, if ever, used alone, and the indications are an exostosis with a minimal hallux valgus deformity. Soft tissue procedures that accompany the bony realignment procedures include a medial capsular imbrication, a release of the lateral capsule, and the types of capsulotomy vary between a vertical wedge, longitudinal, distal base flap, H or V incisions. All of these are used to tighten the capsule as a supplement to the bony realignment procedures. The modified McBride is a lateral release of the abductor hallucis tendon, which is one of the primary deforming forces, both producing valgus and also pronation, releasing the deep transverse ligament, which is attached to the lateral sesamoid or fibular sesamoid, and a lateral capsule release of the first MTPJ. These are all used as an adjunct to the bony procedures, and in the congruence of the joint is the main indicator. Now, this is a schematic showing the distal Chevron osteotomy, which was common and is still used. It is a distal V-shaped osteotomy of the proximal of the metatarsal head itself. A scarf osteotomy can be either translational or rotational, proximal or crescentic man osteotomy, a modified lapidus, and an Aiken osteotomy. And these are the most common types of procedures in an orthopedic practice. Distal Chevron osteotomy is technically fairly easy. It is stable. It can correct an elevated DMAA angle with biplanar osteotomy. It's a reliable procedure for mild and indeed moderate hallux valgus. 80 to 90% of patients are satisfied, and the average correction of the HV angle is 12 to 15 degrees, and the IM angle around 4 to 7 degrees. It is a limited correction of sesamoid subluxation or hallux pronation, and therefore higher satisfaction rates with low to moderate IM angle discrepancies. Now, the complications of a Chevron osteotomy are recurrence in around 10 to 14%, and AVN of the metatarsal head, and this is often questioned on board exams. There's up to a 20% incidence of AVN, and there's a greater incidence of MRI-diagnosed changes in vasculature in and around the head, but mostly the incidence of AVN is anything from 0 to 20%. This is not a benign complication, as AVN can be truly catastrophic to the biomechanics and therefore to the clinical symptoms of the patient. We have to respect the safe zones when we are operating on these patients, and when we're doing a metadiaphyseal osteotomy, we need to be careful of the superficial branch of the medial plantar artery, which is coming just at the metadiaphyseal angle on the plantar surface, and the deep branch of the first dorsal metatarsal artery, which is at risk when we are performing the modified McBride, along with the distal Chevron osteotomy. Now, the limitations: it can only shift a fragment 4 to 6 millimeters and maintain adequate bony contact. The goal is to get the IM angle less than 10 degrees, and a 5 millimeter shift at most will change 5 degrees of correction, and therefore you can see that the distal Chevron osteotomy should really be used only in mild to low moderate IM angle changes. There is a biplanar chevron which removes a medial wedge, allows more medial rotation of the capital fragment, and is useful in cases of high DMA angle. A scarf osteotomy is the most widely used bunion procedure in the world. It's a translational osteotomy. An angular correction is also possible. It has excellent stability, allowing early range of motion and early weight bearing. Indications are a moderate to severe HV angle and an IM angle of greater than 15. Reported outcomes of this have been excellent. It's a three-dimensional correction capable of multiplanar correction, including that of the DMAA. There are complications associated with this. There is a learning curve associated with it. Intraoperative fracture is not uncommon, particularly with overcompressing the screws. And troughing is one of the early experiences that Chris Coetzee reported, where the fragment was translated, the dorsal fragment, over the plantar fragment, and in doing so made trough when the screws were tightened. And this created angular deformities and shortening. Now, this has been addressed using a rotational type scarf osteotomy, and the results of this show that there is no troughing, and in fact greater IM angle correction can be achieved. But in doing so, we must always be aware the DMAA angle has been altered, and therefore we must typically use an Aiken osteotomy with a scarf osteotomy. We'll explain that a little later. A lapidus is again the second most common operation used to treat a hallux valgus. Its indications are severe deformity with a large IM angle, hypermobility of the first MTC joint, collagen disorders including Ehlers-Danlos, and this has been a board's question in the past, first MTC arthritis, a metatarsus primaveris, and concomitant pes planus. When you're addressing a posterior tibial tendon deformity and you want to restore the tripod in a patient who has an associated hallux valgus, then a lapidus is the appropriate choice of procedure. It has a three-dimensional correction, but the complications are not uncommon, and it is a non-union rate of up to 12%. You may also develop metatarsalgia due either to shortening or resecting too much bone away to allow bony apposition for healing, or indeed dorsal and plantar flexion, which may lead on to central metatarsalgia. Now, the complications in general of hallux valgus surgery are recurrence, inadequate soft tissue resection, sesamoid incongruence, failure to recognize high DMMA angles, and juvenile hallux valgus has a recurrence rate of up to 50%. ABN we've discussed from a medial capsular approach and distal osteotomy associated with modified McBride, and is most often associated with a Chevron osteotomy. Malunion is associated with transfer metatarsalgia due to dorsal malunion, and hallux valgus. Hallux varus is an overcorrection of the first IMA angle. An excessive lateral capsular release with over-tightening of the medial capsule is often associated with this, and a fibular sesamoidectomy and overcorrection with Aiken. The nerve injury most commonly associated with hallux valgus surgery is a medial dorsal cutaneous nerve, where patients may develop a hyposthesia or dysthesia along its distribution, particularly into the medial aspect of the great toe. Now, these are some questions that have arisen from previous exams. 45-year-old woman undergoes surgical correction for hallux valgus. A year later, she develops with painless deformity as shown here, which is clearly hallux varus. And the treatment of this will include all except resection of the tibial sesamoid as a resection of the fibular sesamoid. As resection of the fibular sesamoid, AVN of the first metatarsal head, excessive postoperative banging, excessive medial capsular reefing can all produce this, whereas a resection of the tibial sesamoid would typically not produce this deformity. 47-year-old female presents with persistent left great toe pain. 2 years later, she underwent a hallux valgus corrective surgery with a Chevron. Figure A exhibits her most recent radiograph. What is the most likely diagnosis and treatment? This is a clear diagnosis of osteonecrosis, and an MTP arthrodesis would be the most appropriate treatment. It must be underscored that MTP fusion is not easy here, as this is dead bone, and this would require certainly excessive amount of bone graft to restore length to this, but nonetheless an arthrodesis is the appropriate answer. 38-year-old woman has 2-year history of left greater than right foot pain. On examination, first MTP dorsiflexion and plantar flexion with a deformity that passively corrects. Hallux HV angle is 31 degrees and the IM angle is measured at 16. This is one of those questions that really requires you to know the algorithm for surgery here, and the choices are a Keller, a distal Chevron with modified McBride, scarf with modified McBride, lapidus, or modified McBride in of itself. And the answer to this is obviously a scarf osteotomy. The IM angle is moderate. Distal Chevron would be used in a smaller IM angle, and a lapidus would be used with a hypermobility and a large IM angle. Next question is a 57-year-old administrative assistant who has pain from bunion of her right foot. She has hypermobility of the first ray, and therefore a lapidus type procedure is chosen. Each of the following are associated with a better clinical outcome except dorsiflexion unloading of the first metatarsal. You can imagine with dorsiflexion, the tripod effect has been lost, and therefore excessive weight transfer will now go through the second and third or the central metatarsals, leading to either a stress reaction or stress fracture of either of these bones, or indeed a central metatarsalgia or overloading of the central metatarsal. A 67-year-old female presents with bilateral foot deformity. All of the following contributed to the risk of recurrence after surgery, with the exception of resection of the lateral sesamoid. The next question is a 55-year-old female attorney has progressive pain and deformity of the great toe. Pain is localized in the prominence of the medial metatarsal head. Which of the following best describes the hallux deformity? It's either valgus and supination, valgus and pronation, valgus and hyperextension, varus and supination, and varus and pronation. And we know that the answer to this has to be valgus and pronation. Next question, there's no clinical picture along with this. It simply asks which of the following clinical scenarios regarding hallux valgus could be appropriately treated with a modified McBride procedure. And the answer to this is a 35-year-old with a 20-degree HVA and 11-degree IMA with an incongruent first MTP joint. It must be noted, however, that it would be extraordinarily rare just to do a soft tissue procedure alone, and I can't imagine this question recurring. So thank you very much for your attention, and hope that is helpful, and good luck in your exam.